Hello, and welcome to today's webinar, Why Integrating Behavioral Health into Primary Care Has Never Been More Important. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. At this time, I would like to turn the floor over to our speakers.
Good day and welcome. I'm Dr. Rondi Baldi, a primary care physician passionate about enhancing patient experience in primary care. I've worked in clinical practice, consulting, and risk adjustment analytics, and I joined Emcara Health as a medical director. Emcara is a value-based provider delivering primary care to vulnerable adults and seniors in their homes, also known as house calls. And we do this either as the PCP of record or in collaboration with community-based PCPs. I'm joined by Dr. Namita Dookaran, who serves as Emcara Health's National Medical Director of Behavioral Health Care Solutions. Board certified in internal medicine and addiction medicine, Dr. Dookaran is skilled in the care and clinical treatment of persons with serious mental illness and substance use disorders. She's practiced and held leadership roles across outpatient and residential dual diagnosis addiction treatment centers for opioid and alcohol use disorders. Dr. Dookaran completed internal and preventative medicine residencies and received her doctorate from a joint program at Dartmouth and Brown. I'm also joined by Debbie Del Rosario, who is the Director of Behavioral Health Clinical Programs for Florida Blue Cross Blue Shield. As director, Debbie is advancing behavioral health integration across Florida Blue's primary care provider network and oversees case management, quality improvement, and quality measurement activities. Debbie brings over 2 decades of clinical operations and managed care leadership experience to her current role, having worked directly within behavioral health organizations and TRICARE. She started her career as a licensed clinical social worker, providing clinical care to adult and geriatric populations and persons with serious mental illness within community mental health centers. And finally, I'm joined by Angela Kypriotis, who manages behavioral health and social services for Allegheny Health Network. In this role, Angela oversees the integration of behavioral health into primary and specialty care practices. She's built a regional program to integrate social work support to primary care practices and their patients around social determinants of health needs. Angela also brings more than 20 years experience in a variety of social work and mental health settings. And just a bit about Allegheny Health Network. It's an integrated health system serving Western Pennsylvania, parts of nearby Ohio, West Virginia, New York, and some parts of Maryland through 250 clinical locations, including 14 hospitals and 90 plus primary urgent specialty outpatient practices, as well as outpatient surgery centers. So welcome to our panelists, and welcome to those who joined us today. So before we get started, integrated behavioral health can mean different things to different audiences. So I thought it might be useful for us to level set about how we're defining integrated behavioral health for the purposes of our discussion. Maybe Namita, you can start.
Sure, Rondi. First of all, before talking about integrated behavioral health, I think we step back a little bit and say, what does behavioral health mean? Because that terminology is used differently by different individuals. So for the intent of this discussion and about behavioral health integration, the definition is intentionally broad and inclusive, encompassing behavioral factors in chronic illness care, care of physical symptoms associated with stress rather than associated with disease, health behaviors, mental health challenges, including history of trauma, thinking patterns that might affect resiliency, and substance use disorders. And in thinking about integrated care, I like thinking about a fusion of the ARC and SAMHSA definitions, which defines integration as the care a patient experiences as a result of a team of primary care and behavioral health clinicians working together with patient and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. And SAMHSA goes a little bit further, saying it also means addressing social needs. It is integrated and coordinated. And it doesn't necessarily have to be co-located. Co-location in itself is not integration, although that could be a component of integrated behavioral health. An emphasis with effective and systematic screening, identification, and linkage to evidence-based treatment modalities.
So it sounds like in that initial definition, there's an emphasis on the whole person and all of the different experiences they might have. If we go back 20 years, we started talking about integrating behavioral health in terms of the collaborative care model with other areas of care. And this model doesn't seem as though it's taken hold broadly. Angela, why do you think the concept of integrated behavioral care is getting more attention now?
Yeah, hi. Hi, everybody. Thanks. Yeah, I think now we really truly are looking at whole person culture shift, right? Just that emphasis, like Namita said, on the whole person. And in our system, that's really been a couple of years in the works of looking at the PCMH, patient-centered medical home model, trying to just bring that, the wealth of services into primary care, which not just for behavioral health, but dietitians, pharmacists, these other specialists that allow physicians to really spend more time doing the work that they're trained in and the work that they want to focus on. And really, they feel ill-equipped, I think, often to manage some behavioral health issues where we can't often get patients into other community resources that maybe historically were able to manage some of that, but that now falls to the primary care physician. When a patient can't get care anywhere else, they're going to come back to their PCP. So I think that's really what kind of had us looking at the collaborative care model and start doing that work in about 2018 is when we started doing that.
And Debbie, continuing with you, certainly the pandemic has revealed a lot. Tell us what the pandemic, you believe, has revealed about the need for better access to behavioral health.
Yeah, I think definitely the view overall is that when everybody moved to at home, there was an increase in anxiety, there was an increase of depression, and we see even with Biden's State of Union that we've identified that there's a mental health crisis at this time. We are definitely looking at everything from substance use concerns as well as what they're calling now COVID post-pandemic stress that's indicated at this time. And what we've seen is a good linkage at moving forward is being more creative in many ways, such as looking at telehealth, teleopportunities when those individuals were not being able to access services in the actual doctor's office. Or as we're seeing right now, is that if we're not able to connect with a behavioral health provider, is there services our primary care can facilitate to manage that individual?
I think both you and Debbie, you and Angela raised issues around how we can enhance primary care overall as a result of integrating behavioral health and letting physicians kind of do the best care they can do and supplementing with other staff and other services. So we talked a little bit about why integrated behavioral health is more of a prevalent conversation, but let's talk about how integrating behavioral health into primary care settings improves access. And Namita, let's start with you.
So we have been talking about behavioral health for decades, as we've said a little bit about already, and been talking about behavioral health integration for decades. And as we look at models out there, there are thousands of organizations that have implemented integration of behavioral health in some form or fashion. That being said, there's still a lot of work to be done. Our providers in the field, primary care physicians, are doing the best that they can within the limited resources that they have. And primary care in general needs more robust funding and support and services to provide care for the whole person, body, mind, biopsychosocial, spiritual. We have limited behavioral health resources in terms of the provider workforce specialists. We have patients who may or may not be open to seeing a behavioral health provider, going out to see someone. The hoops and different paperwork that they might have to fill out to see someone, to call a separate person in a health plan to get a referral. There's still a lot of stigma out there. And I would go even back saying that providers, as they try to provide care, we're all doing the best that we can, and sometimes we think we're doing a good job, even with anxiety and depression, but there is a whole other level of quality. There's a gap which can be addressed by embedding behavioral health clinicians within primary care. It's not just about adding service lines or increasing service delivery options. It's about enhancing the care and working smarter, not just harder. So how do we deal within the current resources and funding that we have? How do we integrate effectively to increase access to care and reduce stigma, embedding these services within primary care? We in MCARA, in our innovative home-based model, are doing that on top of a foundation of also addressing social determinants of health with community health worker involvement, because as I've heard it said, you can't have health without mental health or behavioral health. I don't think you can have behavioral health without also addressing social determinants of health. And having that comprehensive model, we are using the collaborative care model with some modifications in which a licensed clinical social worker is embedded in primary care to help with assessments of individuals who may be identified by anxiety or depression scores or by the primary care team as in need of additional behavioral health support. And in doing those assessments, being very thoughtful about coming up with a treatment plan with the team that's not just push a button and refer to behavioral health, because sometimes we push that button and refer to behavioral health and it's not very tailored to the patient. And so there are different levels of behavioral health care that our teams are not even aware of. And I learned as I got more into the behavioral health space myself. We also have room to build education within our teams to more effectively manage medications and adjust and titrate, and not just put someone on an SSRI for depression and say we're done. And to track and monitor over time. So in our model, we have the licensed clinical social worker paired with a physician consultant who has expertise working with behavioral health conditions and doing case reviews weekly. And that would be for med management, but this is a combination of access to counseling that is primary care tailored and that's evidence-based, shown to improve outcomes, tied with more effective med management within primary care, and then more thoughtful strategic approach about if and when someone needs external behavioral health referral, what really do they need? And working with our health plan partners very intentionally in collaborating and streamlining those flows as well, so they get where they need to go as quickly as possible with the least amount of hoops and barriers.
Angela, is there anything you would add to that?
Yeah, sure. I'm just gonna do my mic here. Yeah, I mean, like you said, strategically assessing and making sure that the patient gets connected to the right level of care. So we have kind of outlined our own tiered system within our health system. So we work collaboratively with the Department of Psychiatry, and we want the behavioral health consultants in the primary care offices and in the specialty offices to be the first one to assess and triage those patients and determine if they need that next level of care. We want to connect them to that level of care, but we also don't want patients to kind of skip the introductory levels in the same way. I always refer to it as if someone thinks they need knee surgery, for example, they don't just go straight to the surgeon, right? They first meet with physical therapy, or they have an injection, right? Like, so we're trying to see what other levels of care might be more appropriate, instead of just kind of jumping to the top, highest level of care. So that's really the approach we're using, and has worked. We found to be successful.
Debbie, it sounds like both Namita and Angela are describing, right sizing and getting the patient to the right level of care. And that happens when their behavioral health staff or consultants kind of supporting the primary care staff. Have you learned anything else in terms of how access is improved? Also, Namita mentioned there's reduced stigma, so access may be improved as patients are more willing to receive care from providers they've had for some time.
I think one of the things that's been great is that there's been more awareness that we need to start asking the question. I think that has been a huge shift. There has been more providers who are asking, through measurement-based care, asking those questions. How is that individual? Asking them specific, maybe depression questions, or depending on the services they need, to substance use. Are they going through trauma? Things like that are specific questions they can evaluate where the member is at this time. And then based on the response and using those measurement-based care tools, they can assess the right treatment that might be applicable for that individual and their symptomology or where they're at. So it's great to be able to use those tools. For like on the medical side, you would have thermometers, you would have being able to do lipid tests. From the behavioral health side, using measurement-based care is the right way of evaluating where somebody is when you first started meeting them, based on the recommendations that you put forward to them if they follow through, and then reevaluating them after a certain amount of time, making sure that services that were being provided met those needs. And if not, adjust, make those changes, making those movements forward, again, to get that person to that steady state.
Mm-hmm. If I may just add quickly to that, I completely agree with Angela. And having well-implemented SBIRT screening, brief intervention, and referral to treatment can save lives, reduce costs, and reduce hospitalization. So that identification piece and how we ask the questions, when we ask the questions, how do we do the follow-up, are all as important as what kind of treatment we link them up to. I think one big, maybe slight elephant in the room is that a lot of people are highly functioning and can seem to be well compensated. And underneath the surface, there are challenges that they're dealing with. And we as providers have to go against our preconceived ideas and pretest probabilities so that we don't ask questions to say, well, you don't have depression, do you? And lead in a way that doesn't encourage patients to be open and feel that they're in a safe environment, and then in which we will help them with their different needs.
Mm-hmm. Well, we're moving into talking about how to implement integrated models, but before that, maybe we'll just talk a little bit about how health plans can help expand access to integrated behavioral health. So Debbie, given your experience, why should health plans work to offer integrated models?
One of the things that we've been looking at is that a number of these provider groups, when you look at your overall population, the majority of these individuals may have a behavioral health condition, and of your general population, maybe 28% of them have a behavioral health condition. But when you look at their total medical expense, how often are they going into the emergency room? What are the medications they need? Are they returning back to the hospital? Those individuals, again, with that behavioral health condition are sometimes 3 to 4 times higher than somebody who doesn't have a medical or a behavioral health condition, and their total medical expense could actually be 45% of your population. Again, it's just that constant return to the hospital that's causing that impact to them. What we've seen is, again, looking at those individuals with those comorbidity situations, finding ways to bring them to a more steady state, is looking at when you can find some intersections. Again, when are they needing some treatment, finding that right resource for them so they can, again, connect with somebody on hopefully at a lower level of care instead of returning back to the hospital time and time again after that.
And Debbie and Angela, have you seen that your plans for integrating behavioral health also align with existing programs and services you have to expand access to care more broadly?
Yeah, I'll jump in before Angela. Yeah, here with Florida Blue, we are definitely outreaching to our different provider groups out in the community, validating what services are they doing. What are they looking at? Are they doing measurement-based care? Are they tracking their remission and response rates for those individuals, so they can track the progress? Are they aware of what kind of services is right to connect some individuals for behavioral health care? Are they moving forward with a collaborative care model? Is that a place where they are ready to move forward in that direction? Are they interested in hiring a staff member and being a part of their group to doing psychotherapy services within their organization? There's that opportunity as well. Or are they looking for a provider with through their behavioral health network? But again, finding the right levers, what is right for that person based on their symptomology, based on their clinical presentation, and leveraging the right resources with them. Angela, what is your experience?
Yeah, I mean, we're certainly trying to expand all types of behavioral health services. It does kind of create kind of a balancing act, right? Because we work with the Department of Psychiatry, but we're contributing to their backlog because we're identifying more patients now than we have before. And so we're also, having to come up with ways when patients call in and they're calling the therapy line or trying to get a hold of a psychiatrist or psychologist, kind of having the folks who answer the phone also say, well, let me see if there's someone in your PCP office to kind of close that loop so that the patient's not waiting. Because often there are wait lists of 10, 12 weeks sometimes, and so just working to try to hire more long-term therapists and mental health clinicians, while at the same time, doing more of this early intervention and brief intervention model that we're using for collaborative care. But it does create, right, like identifying more patients is a good thing, and identifying patients who need help earlier is a good thing, and it contributes to the additional resource needs for behavioral health overall. So it's a tough balancing act for sure.
May I comment quickly on that? So the other thing that I'm going to make a plug for is, in addition to increasing access to mental health, is increasing access to substance use disorder treatment. And while we've been talking about behavioral health integration, I'm thinking, what are the barriers for why health plans have not been able to do this as much as one would have expected, given how many decades we've been talking about some of these things? AHIP has mentioned in a recent article some examples of health plans and what innovative strategies they're using for behavioral health integration. So it is happening, but I think there are still some challenges there in trying to figure out how a health plan can do this, knowing that it improves quality and it ultimately will it leads to good clinical outcomes and more effective utilization and less use of the ER and the hospital. But some of these outcomes, those utilization outcomes, come later, and the process and the quality measures and the access are the areas of focus, I believe, in starting the integration and not expecting overnight results. I recently read about Virginia in what they did in terms of increasing access to addiction treatment by improving or increasing the reimbursement rates for addiction. And in the midst of it, it actually led to the provider workforce for behavioral health increasing. more diagnoses identified, and ultimately decreased ER and hospital stays. And in a summary take home, they said to be able to effectively integrate behavioral health, there are 4 things that you need, which I resonated with, is very, very much collaborative involvement of all stakeholders to come up with strategies. They transform the benefits and services by thinking more about evidence-based treatment modalities for addiction treatment, like using the American Society of Addiction Medicine criteria to know what's an appropriate level of care. And I would add to that also now ASAM is trying to implement certification for levels of care, especially residential, which could be sometimes a wild, wild west, and health plans don't want to pay for something that they don't quite know whether it's evidence-based and it has certain components that have been shown to be effective. Thirdly, improving the reimbursement rates for behavioral health care. And then fourthly, innovative value-based programs to support integration. So those are things that I think we really need to be thinking and talking more about. And Florida Blue has been working with us for some of our value-based population partnerships. It's been great to be working internally on building our systems within the primary care space, and also learning who the health plan leaders are in Florida Blue in a behavioral health space to say, okay, how do we streamline this? So we're also having integration of what we're doing and what services you are offering, so we're not siloing in that way as well.
I just thought of something when you were sorry.
Go ahead.
I was just saying that was Navita was talking. I was thinking of another conversation we've had with a health plan lately is around reducing or eliminating copays for things like depression screening, right? Because patients, it's a big patient dissatisfier when they come to the doctor, they get their copay for their PCP visit, right? And then they get another copay for depression screening or some other type of screening. And they're like, well, why do I need this? I'm not depressed. But we're like, well, we're screening everyone, and they don't want to be charged for these little things here and there. So kind of figuring out ways to include those all into and it speaks to the value-based reimbursement as well. But including more of those type of things and visits so that the patients aren't feeling like they're getting charged for each individual service.
Mm-hmm. So you all have already been talking about, if we want to help other health plans, how to implement an integrated model. You all have mentioned systematic assessment and identification, kind of early intervention, getting patients on the right pathway to the right level of care. And then you've even started talking, Angela, about endemicity, how do we pay for this, and how do we make it so there are not cost barriers to patients, but health plans see the benefit of innovating around payment to providers for this integration. So maybe, Angela, we can go back to you. You're working in an integrated health system already. Give us an example of how you all are implementing this in clinical settings, and you're also, trying to expand social work support for social determinants of health as well. So in terms of, successfully integrating with different practices, give us examples of what you focused on or what you've seen that could really be insightful for other plans.
Sure. Sorry about that. Okay, thank you. I think the person who walked by is gone now. So yeah, how we implemented, we started smaller in the beginning, but really getting that physician champion buy-in and leadership buy-in for the model. We had to do a lot of education and explaining what the model is, that it is evidence-based, that we're not trying something completely experimental. We're not coming up with our own new, model, it's a model that's been shown for 20 years to be effective and has been researched. So that was part of the initial conversations. But we did look at a variety of different models to see which ones would fit the best. And we did choose collaborative care because it was CMS. CMS was advocating for it, had just created CPT codes for it in 2017, right before we started this conversation in 2018. So it really seemed like it would fit with what we needed. We wanted to have folks who were sitting in the practices for the most part, and the providers were just really looking for someone additional expertise, right, that they didn't feel like they had. And so that's implementation in the early stage was a lot about education and showing them this could really work. And then once you start something like this, right, then the word spreads, and then the physicians are like, well, I have this thing in my office and you should try to get one of these people in your office. And then the physician's like, well, when is my turn? And we were rolling it out progressively in stages, and so we couldn't just hire them all for everyone. But it was really a piece that physicians started requesting and asking for, and when am I going to get this? So
Namita, thinking about Mkara, where we're trying to integrate this into home-based primary care, what seems to work? What's worked in our setting?
Well, in our setting, because we are in the home, there are things that we are able to identify that maybe we would not in a office-based setting, and also in terms of access to care and transport issues. Those things are mitigated, if not eliminated, by being in the home, whether we have a CHW, a field nurse, a nurse case manager, an APP going into the home, or our behavioral health care manager interfacing with the patients. In terms of what we're doing, we are trying to leverage tele as much as possible so that the behavioral health care manager is not spending his or her time going into the field, just spending driving, while recognizing we need to have some sort of flexibility that if someone has some sort of paranoia related to screens, or people might be listening in on the conversations, that there's got to be some room for in-person visits as well. That being said, because we have community health workers who are in the field, we are also leveraging them for tele-assisted visits in the situations in which patients may not be tech savvy or may not have the family assistance to help with such. And the CHWs may also continue encouraging the patient in self-management in between psychotherapy visits with the behavioral health care manager. We're also adding on, or we have added on, components of integration in presence of a behavioral health clinician within our multidisciplinary team meetings. And that's been adding a different element in the discussion. So sometimes a community health worker hits a wall and says, this person is not adherent with X or Y, and I just can't figure out why. Or suddenly it just comes up out of the blue, oh, this person has a history of PTSD. You say, wait, stop right there. There may be some sort of a linkage, and we need to go back to some of the root causes of that rather than just listing it as a past medical history. And so it's really opened up the platform for more dialogue on the things that might be contributing to the high readmission rates for heart failure, acute MI, and pneumonia. It is known that depression and anxiety are associated with those things. So when we say someone's being admitted for X or Y, recognizing that there is that hidden element of contribution of mental health and substance use disorder treatment. At this point, we haven't targeted strategically substance use disorder treatment, but that is one of my let's call it my special interest, because I truly believe, as a generalist, I was in primary care as well as in inpatient medicine before I segued more into addiction medicine. I truly believe it's possible for primary care teams to have greater capacity to treat, especially alcohol and opioid use disorder, with outpatient withdrawal management and treatment within the primary care space. And that could really open up the doors for so many people who can't take time off of work even if they were to qualify for a partial hospitalization program or residential treatment program for addiction. So I think there are many different layers there. I have read that for every dollar spent on addiction treatment, it saves $4 in healthcare costs. And so these are some of the things that we'll be looking at moving forward. And I think continuing to raise awareness even within our teams that even the 2020 Milliman report on costs, how do behavioral health patients contribute to physical and mental health care costs? They estimated a quarter of the population, or the 21 million covered lives, have behavioral health conditions. I think it's probably more than that. And while 25% have those conditions, just 4.4% of the total healthcare costs are for behavioral health. And of the top 10% of utilizers, or of top 10% costing the healthcare system, those who have behavioral health, in that top 10%, they are 6% of the total population, and they account for 44% of the total population of healthcare costs. That is staggering. We have a lot of opportunities to improve quality, and then that will drive better outcomes clinically, as well in terms of utilization and more effective med management and treatment utilization.
Well, Namita, you just outlined the business case for why we've got to expand behavioral health, and we were going to move into talking about measurement, but I just wanted to give Debbie an opportunity to talk about in the Florida Blue primary care provider network, kind of in terms of implementing. You alluded to it before, not a one size fits all. So how has that worked, or give us an example of that? And then also in terms of case management, have you done anything different case management wise in terms of integrating behavioral health?
Yeah, so our groups, everyone is kind of on a different path. Every value-based provider groups may be leaning towards having the network that they rely on, or they may be looking at bringing things in-house. It really comes down to what they're currently able to do. And what we do at Florida Blue is we outreach to them and kind of meet them where they're ready to move forward with, and making sure they have that right access. One of the first things, or the way that we're definitely tracking success, is that we actually want to see increased, awareness of behavioral health attributed members. Seems like an odd choice that we want to see an increase on that, but it's because we're asking the questions, making sure that they're going through that path. The next is to make sure that they are increasing their behavioral utilization. Definitely want to make sure they are linking with that right group, whether it's for psychotherapy services with a behavioral health provider at their location, whether it's psychotherapy services with a provider out into the network community, telehealth, whatever seems the right connection. Collaborative care can be a great solution to manage the care of that individual, and as the primary care has that psychiatrist consult indicated, and as an expert, they can definitely make sure they are leading that member down the right path. So we've definitely been looking towards kind of, again, where is that provider group ready to go? What we've done on a case management side is that we've identified select groups. We call them complex chronic populations. So it's individuals with medical inpatient, as well as some severe behavioral health conditions, or major depression, bipolar, schizophrenia, that we've identified that with their medical conditions, their likelihood of them continuing to return back to a hospital setting, again, utilizing emergency services, increase of medications, that may be a good group. We want to validate that they are connecting with that behavioral health outpatient provider, because a lot of them don't. They have been identified, they've been classified as somebody who has a condition, but they haven't linked and haven't followed up with that right next resource. And we just want to make sure that they're aware of the opportunity, but that we educate the member of what they need to do and why it's so important to stay on that lower level of care with an outpatient provider. And if they don't have a provider, linking them with one, giving them some of it that they can use and move forward with it. So those are some things that we're doing with care manager, case management departments.
Great. Well, you all started, I think, talking a little bit about how we might measure success. both clinically and operationally and financially in terms of implementing integrated behavioral health. And maybe, Angela, we'll start with you. How have you all at Allegheny Health Network started to think about measuring success? And yeah, tell us how you thought about that.
Yeah, well, the PHQ-9 is probably the easiest and most commonly used measurement, at least for depression. There's the GAD-7 is used sometimes with anxiety, but we're not as consistently using that tool. With the PHQ-9, it's more of a consistent policy in place for depression screening. So we look at measurement that way. That's one simple way to kind of clinically measure, but we're seeing patients of all different diagnoses. So, the PHQ-9 doesn't always reflect that. We're also looking at costs. We're part of a health system that is under the umbrella of a Blue Cross, a Highmark plan. So we're able to look at claims. So we started looking at some data actually right before COVID, and then because of COVID, we kind of changed. I think people mentioned earlier some of the workflows and had people working remotely, and the model was a little different during that time. So we struggled to figure out how to do kind of pre and post measurements with that kind of COVID window in there. So we're now kind of regrouping and pulling some of those months, at least the most severe months when our staff were all removed from the practices and that kind of thing, to see, to start looking at that again. But yeah, we looked at cost of medication, which we know in some cases in some of our preliminary data did go up a little bit. That's okay, because we want patients to be on antidepressants and anti-anxiety meds and those things when they need them. And, we're just looking at engagement. Like you said, we'll be able to see if patients, at least certain patients through claims data, whether they did get connected to a longer term therapy need or longer term another level of care. So just kind of looking at all of those things and just their overall cost of care, right? So somebody mentioned, is their diabetes care improving? Are they going to the hospital less often, not just for behavioral health, right? For other things, other conditions. So we're looking at a variety of things and trying to also compare offices that have a resource assigned to them versus offices that don't, and whether those populations look differently as far as outcomes. So it's certainly a challenge, but COVID has complicated things a little bit, but we're getting back on track with that.
Mm-hmm. Mm-hmm. Namita, Debbie, in terms of how are you measuring success? Maybe another question too is, how are you measuring integration? How are you looking at your model or your system or your primary care provider network, Debbie, in your case, and assessing, how well we're doing at this integration? So kind of two things. Debbie and Namita, how are you measuring success, and then how are you measuring advances in integrating the care?
Yeah, so as Angela highlighted, it's a little bit challenging in figuring out what the measures should be. And I think kind of breaking it down into short, intermediate, and long-term goals and what's the end game. I think short-term and priority is access. And as there is greater access and less stigma, there will be greater identification of conditions. So I like what Debbie mentioned about we actually anticipate that our diagnoses of behavioral health conditions is going to increase. It's not that they weren't there before. We know about them. And then our reach rate and an engagement rate, once we identify how many of those individuals actually end up engaged in care versus what we traditionally would do, push a behavioral health referral button, and then patients may or may not get there, may or may not get in a timely manner, and may not continue follow-up care with those providers. Following the PHQs will be is one component of it. Although the things that people are coming to address to the table with the team are a broad scope of things. The collaborative care model, it first was found to be effective with anxiety and depression populations, and since then it has expanded on to show some evidence in folks with trauma, substance use disorder, opioid alcohol use disorder, ADHD, and working intentionally with a behavioral health care manager on measurement-based treatment to target The psychotherapy in primary care is tailored to be about 6 to 10 sessions, and if they go beyond that, they get referred out with continued collaboration with the care manager as needed to facilitate that. But also measuring how many of our individuals are able to graduate from care management with our behavioral health care manager and more stable. The diabetes control that has been associated, with mental health challenges is poor diabetes control. So I could see down the road some of those other outcomes getting better. I think one of the unintended positive consequences that we might see that has been hinted at least by one health system in Alaska, is the not on a patient level, but on a primary care team productivity level, that the throughput of the primary care team increased with less primary care resources, because now they were not spinning their wheels as much, trying to figure out things, spending 45 minutes in a visit with a patient, but not quite sure how to direct and tailor addressing those needs. And so building those workflows and collaboration between the primary care team and the behavioral health clinicians, it allowed them to see more patients and focus on the physical health, joined at the hip with their behavioral health partners. So I could see down the road those would be some unintended positive consequences, although hard to measure from the get-go in terms of KPIs.
Yeah, I think
Anything you
Namita
want-
said pretty much everything. I was about to say, I mean, I kind of lump it into 4, which is exactly what she indicated. You know, we definitely want to see an increase of the identification, so we are anticipating an increase of members with an attributed behavioral health condition. We're anticipating and hoping this will cause an increase of utilization for behavioral health services, again, connecting them with that right access. Based on that right access and identifying them, we're anticipating that the total medical expense for this population should decrease. So that's something that we'll be monitoring and evaluating. And then the last piece, of course, is just tracking the remission relapse results that they have for measurement-based care. Again, it's a clear way of identifying kind of how people are progressing onwards based on the treatment, and are they making progress in it. So that's what the 4 areas that we're looking at.
Well, I want to thank you all. We have concluded our formal panel session, and I want to see if anyone in the audience has questions, and then I'll have you, our panelists, give some final thoughts. So one question is, how do we increase access for substance use treatment? And we've alluded to it before, that maybe that's an area that may take more effort or be more challenging in terms of expanding access within primary care. What are your thoughts, or what has been your experience in terms of finding champions, increasing capacity, or getting substance use treatment staff linked to primary care? Angela, do you want to start?
Yeah, I'm happy to start. We actually have a grant through SAMHSA for SBIRT. So we did start screening in several offices, not all of our offices, but for part of this project. So yeah, I think our issue in Allegheny County, mostly, which is where most of our practices are in Pennsylvania, we have access to substance use treatment for patients. It's just getting them to agree that they're ready for that stage, right? So the stages of change, I always say motivational interviewing is a really key component of any kind of case manager or behavioral health specialist who's working in a practice, because the physician may, or their care team members may identify that a patient has kind of high risk drinking or other substance use. For example, alcohol is the one we see the most common, as the most common. But that doesn't necessarily mean that the patient's ready to take a step to go to a formalized treatment program. And so what we always do is we talk a lot about, well, we're not providing substance use treatment per se, because we're not substance use licensed, drug and alcohol providers, but we are helping the patient through those stages of change so that they will be ready at some point, hopefully, to to take that next step, and we'll be walking them through those steps. I think historically, I think we've had physicians who are just like, yeah, this patient needs treatment, and I told them where to go, and they didn't go, and then they just kind of were like, that's it. So we're like, well, if we can get them to talk to us about their anxiety or their depression or whatever else other stressors that are going on in their life, we can work through that, those pieces. But it's certainly, I think that we haven't really run across a lot of patients who didn't have access to substance use treatment through their health plan. They usually do have some type of access to treatment. Occasionally there's a high deductible, like a $500 deductible or something like that, which could get in the way. But we really, most of the time, we just see that patients aren't ready to take that next step, and they may need to do it more gradually. So we've gone to more of a harm reduction approach, and really are working with patients saying, okay, well, if you're drinking 8 beers a day, your physician's recommending, that's not the best for your heart condition. So let's try 4 a day, right? And so just working through that type of model has helped us get patients to actually reduce and not always abstain completely from things like alcohol.
I would say increased identification, as we're doing with SBIRT, more coverage of evidence-based medications used for opioid and alcohol use disorder by our health plans, removing those barriers and prior auths when possible, and providing more wraparound support and mentorship for primary care providers who might want to do this. Even with training, some are uncomfortable, and there are multiple mentoring opportunities out there through PCSS and otherwise. So you could create a hub and spoke model as an example of being tied to specialists when you're just getting into this as a primary care provider and finding your way. I think also getting people at the points of ER and entry in the ER and being able to start them on medications there, and perhaps continue maintenance in the primary care space is an untapped opportunity. Undertapped.
Yeah, we've done a lot. Undertapped. Yeah, we've done a lot of education with our members. We've done education with our providers, specifically around opioid safety, opioid strategies. We've talked about MAT programs. We actually are very excited about our medication assisted therapy programs that we are working with our individuals with substance use disorders. That we've worked with several agencies that even have detox at home. So, definitely looking at alternatives. I think Angela said it best. When the member's ready to get some services, you want to meet them where they're at, because that might be a small window that you have with that individual. So we are looking at as many opportunities as we can to bridge that barriers that they may have just to get them the services that they need.
Well, as we talked about earlier, the pandemic kind of highlighted the great need for care and services. Have there been other creative ways that have grown out of the pandemic in terms of increasing patient access to care at the point in which they're ready? And maybe this is pre-primary care office. I'm interested, Debbie or Angela, and even Amita, have you seen other ways patients are trying to access services, or have you promoted certain platforms or ways for patients to access services?
We've done a lot of telehealth. I'm definitely working with different agencies to facilitate those connections. Again, it's a great way of getting that member to see somebody right away. The appointments are indicated. There's not concerns of driving to the appointment or maybe finding childcare, anything along those lines. Again, limits that opportunity. So we've definitely supported and seen an increase of that utilization. Also at Florida Blue, we're also looking at digital self-management tools. We're looking at opportunities that the patient themselves may use some resources, online applications, doing some education, cup of calm, things along those lines, so they themselves can maybe identify some needs that they may have, connecting them with right members that they have in the family, or maybe for some support groups. Are they eating? Are they sleeping? Just daily reminders to kind of, again, the basics that we want to make sure the person has everything they need. Positive thought processes instead of negative that just spirals you down into that dark abyss that sometimes they fall into.
Yeah, I would agree. Some self-management tools, online apps and things that patients, say patients historically before COVID, there were a lot of people who never used FaceTime or Zoom or any of those platforms, but because of COVID and because they've seen it work and they've maybe done a doctor's visit or two and started to utilize it, it's definitely becoming more common. Yeah, there's several platforms out there. Somebody mentioned MAT. There are some new platforms that could do substance use treatment online, as well as there's a peer recovery model online for patients who are using or struggling with trying to quit. Yeah, I mean, there's certainly been COVID has certainly definitely helped with the access point. As far as I know, you mentioned transportation, Debbie. That in a city where we are, a lot of times that is patients who live further out in a more rural area don't want to come into the city, regardless if that's to see their doctor or therapist, anything, right? Because they're like, I have to pay to park, I have to deal with traffic, all those things. And so that telehealth has definitely added to that. And even though collaborative care always allowed for that kind of telephonic support and contact, we definitely have seen a higher utilization of that since COVID.
Yeah, I would agree with all of the above. I think that the use of online tools or apps has been great, not just for clinical access, but for a greater access to community resources and peer support and linkage of those community supports also with the clinical arm to provide more of a wraparound care. NAMI has online resources for patients and families looking for help, as well as there are other substance use apps that are funded by grants, et cetera, that have gained more prominence during the pandemic.
Any final thoughts from our panelists? Any topic we haven't covered?
I would say, as we are talking about all of these things, we do recognize that the U.S. Surgeon General back in 2017 talked about drug and alcohol use and the importance of treatment then. The pandemic has only made things worse. We've seen unprecedented overdose deaths. And I am just hopeful that in this world post-pandemic and as we rise out of this, that we will have more payment reform and more innovative ways and more value-based models to try and address the whole person one treatment plan for the whole person and come together collaboratively, all the stakeholders together.
Yeah, I would add also the psychiatry consultant piece. Debbie referenced it a little bit earlier. As part of the collaborative care model, that really has made it a big difference for a lot of our physicians. They used to feel like that they were sending referrals off to psychiatry and hoping that something happened, but they didn't really have good interaction with those folks and didn't know what was happening. And so now that we have a consultant who's available weekly and discussing cases with them, they feel really educated. A lot of times they'll say, oh yeah, I made a note about that and I stick it by my desk so that the next time a patient has this need for titration or whatever, I've learned a lot. And it also helps, really look at the appropriate use of those highest need psychiatry appointment, services, because we want to protect those 1 hour psychiatric evaluation appointments for people who are truly coming out of psychiatric inpatient hospitalization, things like that. And so the psychiatric consultant is a huge component, I think. And also one other thing that comes to mind is some physicians who had kind of inherited patients from maybe a physician who retired or something and who'd been on, patients who might have been on benzos or something since like the 70s, right? So they've been on benzos for a long time. Well, now they're 75 and this isn't healthy and they could fall, like there's all these fall risks and stuff. So our psychiatric consultant has helped our PCPs, get off medications that are no longer safe or that they've been on for too long and kind of look at other options too. So it's just really been a game changer, I think, for us, is that psychiatric consultant piece as well.
Well, thank you all.
Thank you so much.
Thank you, Rondi.
We thank you to our speakers for that great presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.